Hello, everybody, and I'd like to welcome you to our latest Outbreak Management Advisory Board. Just a quick thank you to all of the participants taking part and for your time, which is appreciated, and those at home watching live or after the meeting has happened. I've got a few apologies to give after that welcome. So just in fact, apologies from Phil Metham from the CCG. To give, and also I'd just like to note at this stage that Dr. Andrew Lee has left the CCG. So if we could minute our thanks to Dr. Lee for his contribution to this day. I can see some nods at that stage, but equally could I welcome Stephanie Porter from the CCG, who is taking that place for this meeting. So you're very welcome, and thank you very much for coming along. There might be a couple of other members of the committee joining us a little later, and if they do, they'll suddenly pop up on the screen with obviously their name clearly there if they join the meeting later on. Agenda item 1 is declarations of interest. I'd just like to give anybody the opportunity to declare any particular interest. I can't see anybody indicating virtually or physically, so none to declare. And then agenda item 2 is the minutes of the last meeting, which was on the 21st of October, and also any actions arising that are listed there. Are there any issues or matters raising with the minutes that anybody would like to see? On the action log, you'll see that there are 2 open actions, and these have been outstanding for a little while. Whether we want to close them off. Tracy, could I bring you in at that stage? And perhaps you could best advise us as to whether you think we should close off those actions.
I think it's probably wise to close them off. I know Claire is on with talking to school governors, so I think that will be progressed. And I'm presuming that you have had your conversations for Action 16, and that's quite a long way in the past now, so things have definitely moved on since then. So my advice would be to close them both. Great,
thank you very much. So the recommendation there that we close the 2 outstanding actions and accept the minutes. Could I see all those in favour of that, please? Thank you very much. So a clear majority of hands in favour. Thank you. That then takes us on to agenda item 3, which is our regular agenda item, which is the update on the COVID situation in York. And I'm going to be handing over to Fiona Phillips to lead us through this. Fiona.
Thank you, and I think Chris is going to put a few slides up as well, just to give you a bit of a visual representation of the data. So there has been a summary that's in the pack that everybody's had, so hopefully you've had a chance to kind of look through that. I just wanted to talk through some of the key things to really point out and a couple of changes. So I don't know if you can put those slides up, Chris. Yeah, okay. So if we look at the first slide, so this just basically gives you a representation of what the epidemic curve looks like for us, and this includes data that goes up to the 12th of November. So given what we know about the incubation period of the virus, we haven't really started to see the effect of lockdown on our infection rates yet. We'll start to see that over the next week, really, as we get that data come through. But what you can see is the impact of when we went into tier 2 and the dropping of cases, and also probably a natural drop off in cases in terms of the university population. So we know that when those new households formed at the start of term, we had cases as a result of that, and what we've seen through the actions in the university that they have really started to drop off now. If we go on to the next slide, I just want to talk a little bit about some of the change in methodology in the way that Public Health England allocates cases. So previously what they had been doing is when you go for a test, you put the address that you're currently living at, and then when the test was reported, your details would have been compared against your NHS record, and the address in your NHS record was then used. That obviously impacts on us in York, partly because of the number of students that we have. So, for example, if you were a student who just moved to York, you had a test and you gave your university address, but you were still registered with a GP back in your hometown, then your result was allocated to your hometown. So what PHE have done is they've now gone back from the 1st of September, and they've reallocated all those tests to the address at which you were living when you had the test done. So what that means for us in York is that we've had 659 additional cases added to our data, and you can see the difference that makes on the graph there. So it hasn't really changed the shape of our epidemic curve, but it does mean that the peak that we saw in mid-October was actually higher than we had thought at the time. But actually what you can see in the more recent weeks is, there hasn't really been much difference there. But I think it's just, so that people are aware that has been what's happened. If we go on to the next slide, I think it's just really helpful to kind of see really where we sit in terms of our regional neighbours in the Yorkshire and Humber, and it's a good news story really for York. Obviously we want our case numbers to come down even more, but we are now the lowest rate in the Yorkshire and Humber region, and quite significantly so. So I think that's really positive in terms of the actions of our residents in York. On the next slide, I just wanted to focus a little bit on some of the data around children of primary and secondary school age and what we're seeing in that school setting. So this is data on a weekly basis in both primary and secondary age children. So as you can see, from the start of September, there were a few cases within schools on a weekly basis. We have seen an increase on that, but I think one of the things is to just really put that into perspective. So, so as you see, for secondary age children, over the course of last week, we had 17 cases of that age group, but given the number of secondary school children that we have, actually that's a very low amount. And what we are picking up when we're dealing with cases in schools is that there isn't really that evidence of transmission happening between children in the school setting. So what we generally are finding is that there's a household case, and then the children become positive through that route. So again, I think that is positive and just sort of puts in perspective that we don't have hundreds of children in school settings who are affected. It's a low number. And then just on the final slide here, I think it's important that we keep an eye on deaths. We did say, in September and October, when we started to see cases going up, that, one of the fears is that you then start to see more severity and an increase in deaths. So we have, in the last 4 weeks, there have been ONS have reported 6 deaths of York residents. Obviously, we went for quite a long period where we hadn't had any deaths. So we have seen some deaths, which takes our total up to 178 now of York residents. But looking here, so the dark line through the middle of the graph is all deaths for our baseline comparator 4 years. And then you can see what we're doing in 2020 in comparison to that. So we obviously saw the peak in March to May, but the deaths that we're seeing now are sort of fairly tracking that not usual rate that we see, but obviously it is something that we're keen to keep an eye on. So I will stop there, but as ever, happy to answer any questions on the data.
Thank you very much for that, Fiona. Before I open it out for questions, I'd like to go to Lucy, please, to give us a little bit of an update on how the hospital is coping with these demands. Lucy.
Thank you. We currently have 71 patients in York Hospital that have tested positive for coronavirus. The number of admissions we've seen in both York Hospital and also Scarborough Hospital, which is part of the trust that manages York Hospital, has been increasing. So it is positive to see that the cases and the positive tests in the community are going down. But as we've discussed before in this group, there is a lag before you start to see hospital admissions, and we have seen those increasing in recent weeks. In terms of what this means for us, we're anticipating that the admissions will start to peak in the next week or so. And as you'd expect, we've got comprehensive plans to manage that surge in admissions to the hospital. So we're in the process of enacting the next stage of that now, which will help us to release an increased number of beds for us to care for COVID patients. This does mean that we have to look at our elective programmes, so our planned operations and procedures, and we'll need to postpone some planned operations to manage this peak in admissions. It's important to stress this isn't a wholesale cancellation of all planned work. So you might remember that back in March, for the first wave of COVID-19, we were instructed, in fact the whole NHS was instructed to pause all of its planned work to enable the NHS to mobilise to respond to caring for coronavirus patients. This is in more of a phased way. And with the first peak, we'll continue with, for example, day case surgery, outpatient work, and all of this is with a view to protecting as much of our cancer and urgent work as we possibly can. And of course, emergency work continues throughout. And as in the first wave, we've got the option for us to carry out surgery in our local independent hospitals. We had a fantastic support from them before, and we're engaged in those discussions now about standing that up again so we can continue to do operations as much as we can throughout this second peak. It's important to say that once again we're at it's escalated again to a level 4 national critical incident for the NHS. So it's the approaches all being managed nationally, and the decisions we make will be and are in full consultation with our regulators. And York's also part of a much wider system, and ultimately a national health service. So there may well be asks of us in terms of helping out other organisations in terms of mutual aid, helping out our neighbouring trusts, helping out other hospitals, and indeed also the possibility of us receiving that help if needed.
Thank you very much for that, which is appreciated. So very happy to open it to any comments or questions now, and I'll go to Ian first.
Yeah, thanks, Keith. It was just 2 or 3 points, really. I think just on the case numbers, and clearly, as Fiona set out, it's very positive, and York is a bit of an outlier. I do think we need to avoid being complacent, though. There are some other areas in the region who not so long ago had very low case numbers, and I think it's just to sort of really stress that we definitely need to keep all the messages going out, not be complacent in any shape or form, because it can change rapidly in a very short space of time, and you only need to see what's happened in Hull and Scarborough to appreciate that. I think the other point I would make is there is an issue which the government still haven't resolved yet, but in terms of where councils will land up in terms of when lockdown is released. When you look at the data, there's only ourselves who are in any possible position across the region to probably have the lockdown measurements eased. Now, that might be a very positive step, but it also brings some potential challenges. And in terms of how do you enforce a situation if we did arrive at it, where, for example, York has some slightly less sort of punitive measures in terms of the lockdown. And let's take an example where York was allowed to, reopen some of its, cafes, bars, but actually the whole of the rest of the Yorkshire and Humber were not. That's quite a difficult thing to enforce, and so I think it's just something to be aware of. And then I think just picking up on the point that Lucy made, I think again looking at the data, you can see there are high numbers in Scarborough and in Hull, and those are continuing to rise. Clearly, given the time frame where it takes 2 or 3 weeks for hospital sort of admissions, another 2 or 3 weeks in terms of potential treatment, you've still got a rapid sort of demand probably for the next 5-6 weeks at least, which is the overflow effectively from Scarborough and Hull into the York NHS system. So I think it's something, we are sort of ourselves with the CCG, with the hospital, actively looking at how we can, release beds, do that. But I think it's just to recognise there is a big demand, across many partners over the next few weeks, even though York itself, the cases may be low.
Thank you very much for that, Ian. I could see lots of nods as you were talking about not being complacent, given what we've learned from other areas. Sally.
Thank you. I suppose just following on from Ian's point, with a primary care perspective, practices are equally working really quite hard at the moment to keep as much going as possible. So they're seeing an increase in work because of the number of COVID positive cases as well, while still trying to manage some of the backlog that got paused in phase 1. We will continue to have conversations around what is really important to prioritise and ensure continues to happen right throughout winter, versus whether some things may need to be paused, in the same way that the hospital trusts are having those conversations. And we will always try and maintain as many services as possible. But the reality is that there may well be some slightly more routine things that do need to be paused, especially given that primary care in the last few days has been asked to take a lead role on delivering the COVID vaccine as well. And there aren't a lot more staff that are not currently being utilised to deliver that vaccine. So it is going to take some staff away from primary care to deliver the vaccine, which is clearly a hugely important task. But just to reflect what Lucy said, really, and we're doing that in partnership with the trusts and with social care, and we'll all collectively do what we can to keep as many services going.
Thank you very much for that. I think all of that and the updates also remind us about how long the key workers have been working on this, and how that response is carrying on through winter, through Christmas and into next year. So really to record my, and I'm sure our thanks, whether that be the hospital GPs, public health teams, council staff, police, all frontline workers that are still there and working throughout this. So thank you very much for that. So that update was for noting, and if we could record those thanks as well, please, that would be appreciated. That then takes us on to agenda item 4, which is the communications update. And in a second, I'm going to hand over to Claire, and I understand we're going to be shown a short animation as well. So assuming the technology works, that's a warning that if we could have your attention for, I think, only 60 seconds, that would be appreciated. Claire.
Thank you. So you'll have to wait just a little bit for the animation. I've just got a little lead up to get to it. So if we can put on the first slide, please, Chris, that'd be great. Here we go. So this is my regular update to you all about the different public health communications we've run over the last few weeks. As usual, we're focusing on our key messages, so hands, face, space, and to get tested if you've got any symptoms. And those 4 messages are consistently and regularly applied throughout all of our channels and throughout all of our partner channels. If we can go to our next slide. This is just a reminder, we have 3 different phases of outbreak communications in our outbreak communications plan. Prevent, which is around sharing regular updates to make sure everybody knows what to do. Respond, which is if things start to escalate and we need to respond to increased cases. And in fact, that's changed into also responding to new restrictions or changes in restrictions. And then phase 3, managing any kind of outbreak. Next slide, please. Just a little overview of the types of activities that we might take, of which I'm just about to show you some examples. But before I did so, if we could just move on to the next slide, I thought it might help to see everything kind of laid out a little bit. So at the start of lockdown and since, we've shared regular communications with partners, with different audience groups across the city, and the darker colour represents a more intense period of communications, and the lighter, I think you might call that a stone colour, is when we relax that slightly and have less regular. So we started during lockdown itself with daily updates, and that's now relaxed to 1 or 2 a week. We started with monthly direct mails, and that's relaxed to quarterly. And our Facebook Lives were monthly, but during this period of lockdown, we've gone to weekly, and we'll talk about those shortly. And then to complement our regular communications, which go out every week, as we've just discussed, we're also complementing them with various different campaigns, which are targeting either different audiences or different messages. So everything from safely reopening the city or keeping the city reopened, which I've shared before and shared last week, to showing the different activities that partners across the city are doing to encourage people to wear face masks. Our We've Got It Covered campaign, a campaign that targeted just the 18 to 34-year-old population, which, as you remember, didn't go through our channels, but went through those partners that target younger people. We've done a lot to support the safe return to schools, which is really targeting parents and teachers and people in the education sector. And we're just about to launch our emotional health campaign, which is part of this Outbreak Management Board advisory group, a task and finish group comprised of different partners, which I'll talk about later. But you can see there are 4 campaigns that as yet we haven't really shaped. So we need to do something around self-isolation, and that's because Insight is telling us, National Insight is telling us that more people are experiencing what's known as lockdown fatigue and essentially not engaging with the messages that we need to, so therefore not following the advice about self-isolation. Excuse me. It could be for all sorts of different reasons, from financial to connection with other people to not believing it'll make a difference. But for whatever reason, we need to really ramp up our messaging around encouraging people to self-isolate, particularly as we move into the different approaches for the testing strategy, which Sharon will talk about later. We need to get ready for, we've optimistically suggested tier 1, but whatever we need to do to get out of this lockdown, we need to do something around a transition to support people moving from these restrictions into the next level, whatever that might be. We need to do more around the testing strategy, which we'll talk about later. And we need to do something generally about not being complacent and to continue to engage in all messages, including hand, space and face. So there's still lots and lots to do in the public health space. And there's lots of work we're doing with partners to do that. If we can move on to the next slide. Or on the next one, thanks. So just to remind you of the types of activities that we've done against our communications plan. As always, we share accurate and timely messaging, and we've continued to work with the local media to make sure we either address any inaccuracies or share the current position. So you can see here 2 articles, one about our aspiration to move to tier 1, well, less restrictions, whatever that might mean, and also what we're going to do, our plans for mass testing, mass COVID testing, which we'll come on to later. Next slide, please. As always, we've continued our regular communications, many of which you all have seen. Our resident newsletter has continued twice a week. Our partner and stakeholder, MP and parish councillor meeting newsletter has continued twice a week. We've continued with a weekly business newsletter, which has been really important over the last the last 10 days or so, as we talk about the business grants that are available. And we've continued with our families newsletter, which again has helped with the return to school. And of course, regular press releases, our wrap-up press release every Friday, media interviews and social media campaigns, including a weekly public health video explaining the current measures and the current restrictions and what people can do to help that. Next slide, please. We've continued and we've ramped up how we might engage people through conversation, particularly after the national lockdown was announced, and then around emotional health last week. Also last week we ran a special Q&A just for as a part of Business Week, which involved public health talking about supporting the city return to normal. Just to give you some ideas of reach, to give you an idea of how many people are interested in the Facebook Live sessions, they really are very well engaged with. So we had over 44,000 views of the one taking place on the 3rd of November and the 11th of November. We had over 607 comments, and remember, lots of those are actually questions. So people are desperately seeking clarity, and they certainly were when we moved from tier 2 suddenly into a national lockdown, and what did that mean and what was the difference. And then the reach following the actual live views was 131,000. So pretty extensively engaged in, and something that we are definitely continuing. Next slide, please. And the next one. So tier 4 communications plan was exactly the same as tier 2. You may remember tier 2 was about a couple of days before our last session when we met a few weeks ago. Tier 4 or national lockdown, very similar, a statement from Keith Aston, Councillor Aston, information about what the restrictions meant for council services and what we would be doing differently as a result, and how we would of course be helping people and supporting as always. And you can see here a little screenshot of our website, which immediately changed to reflect the different restrictions that were in place. Next slide, please. Following that, we were really keen to help residents understand what they could still do, and to really start tackling the lockdown fatigue and the fear that people are not able to do things. We wanted to demonstrate what is still possible even within the current restrictions. And so we've shared lots and lots of information about the things that people can do. For example, we've got here examples of Tang Hall, Acomb and York Library being able to use the public computers and collecting items that may have been ordered online, and also visiting local retailers, particularly those in the city centre and in our shopping districts selling different items. Next slide, please. So we continue to build confidence in the steps that we were taking for returning to school through lockdown, which of course is different from previously. So in the spring, if you remember, the children were off school. This time, well, apart from the key worker children, but this time all children were in school unless the bubbles were compromised. And we made sure that we provided more information, helped parents understand how to keep children safe and how safe their children were in schools, and supported schools themselves with health and safety messages. Next slide, please. So this is our testing communications. We do need to do more around this, and we will certainly be doing more testing communications following today's meeting. What I'd like to do is share with you the animation which helps simplify what the local test and trace scheme means, because we know that that has confused lots of different people. So if I can, thank you. If you could put the animation up, please, Chris, just so you can have a little look, if that's possible. Oh, here we go. Nope. Bear with us a minute, please. you. So as you can see, we've simplified what the local test and trace service does for people, really to encourage as many people as possible to answer the phone first time. Our test and trace service, our local test and trace service is phenomenal. And of course, the quicker they can get to people, the quicker they can get on to talk to other people. So we really wanted to help make that simple for people. And then if we can move on to our next slide, Chris, if that's possible. Oh, thank you. Thank you. So testing strategy will follow this meeting. We've talked about what to do when we leave lockdown, more communications about self-isolation. We're starting to plan for mass vaccinations, which includes learning from other people, particularly Liverpool, which is currently going through the mass testing pilot. And we're just about to, it's actually at print at the moment, we're just about to distribute our city, the resident newsletter, which includes another survey to temperature check how the city is feeling about the different measures in place. And of course, we use that insight to inform our next round of communications. So that's all the information I wanted to share about the communications that have happened for the broader communications plan. I just wanted to provide you with an update about our emotional wellbeing communications, which is an action from the Outbreak Management Board, and then with a view to basically closing the action. So we've agreed our communications objectives. We've got a number of partners working with us on this, and we're very grateful for the support. They really have helped steer this campaign as phenomenally and helped us get it into a really good place. Next slide. Communications plan has been agreed, and that is now underway. Our emotional health Facebook live session last week, and we've shared partner information already, and then we're hoping to do a press release and more partner information this week, and it will roll out throughout the course of the month before we move into our next phase. Next slide, please. So here we go. There's information in our city. There's a screenshot there from our Facebook Live that happened last week. We're sharing campaign information and support by partners, and we have our own posters and social media posts that we will share with partners as well through different channels to really signpost the different support available and encourage everybody to just be really open about how they feel, because as evidence has shown us, nearly half the city is really struggling with emotional health at the moment. So if we could go to the next slide. Launch plan is throughout November. There's a hard launch plan with a press release, but also we'll be releasing more information throughout the course of the month. And then if we go to the next slide, we have a plan throughout the course of the year where we'll use key moments in the calendar to really reinforce why emotional health is important and signpost emotional support to try and get people the help they need when they need it. So an obvious one, of course, is Christmas. Christmas is going to be very different for very many people this year, with concerns about families in care home, and of course just the financial implications of Christmas. So we're mapping out a campaign plan with the Task and Finish group itself, particularly Tuve. So thank you for your help, Tuve. And I'd like to recommend that we close this action now as a result of sharing this information, and rather than provide you with regular updates about how the campaign is going, we agree maybe to come back to you in a quarter with a update on the campaign and our next steps. So thank you very much. I'll close there and take any questions.
Thank you for that, Claire, much appreciated. So happy to open it for any questions or comments. I think the action obviously is for us to note all of the work that's gone on, and I'm quite happy to get updates in quarterly, as you say, Claire, on that emotional health and wellbeing campaign. Julia.
Thanks. I just wanted to say well done to Claire. Every time I come on these boards, I think what a cracking job you're doing, Claire. So I just wanted to say that. Really excellent. So well done.
Thank you so much. I have to say it's a complete team effort. So it's my team as well as nearly all of your teams as well. So it's a city-wide effort, but thank you, Julia. I do appreciate that. And I know my colleagues will as well. So thank you.
You disappeared off camera as you spoke, Julia. So to those at home, you would appear like a ghostly voice on their screen. But,
apologies, I pressed the wrong button now. I should be used to all of this by now.
Thank you very much, and thank you for that thanks to Claire's team. Mark.
Yeah, so just really echoing that, the presence of all these messages around the city is really impressive, and again, I mean, talking to both customers and people in my team, it is impressive how good of a knowledge there is of those key messages actually when we test every now and then. So yeah, so just really thanking Claire for that. The other part I wanted to just pick up is, in terms of planning forward and at the point where the messaging hopefully changes into something, dare I say, more positive, yeah, and more conducive to city recovery and so on. Is that something that would be kind of brought to the board in the future?
Yeah, absolutely. So that's part of our transition away from these restrictions into the next level. So yeah, absolutely, we'll bring that back. Hopefully we'll have something to share next time we meet.
Great, thank you.
Thank you.
And also, Claire, I was going to say that temperature check in our city, and I know you bring regular updates on that, but I think that would be quite useful for us to look at as well, in terms of how residents are feeling, thinking, and responding to the guidance, and as we go along.
Yeah, absolutely, sure.
Thank you very much for that. So with those questions and noting that update, we'll now move on to agenda item 5, which is the subgroup update from universities and higher education. And I'll hand over to Charlie. Thank you.
Thank you very much, Keith. I've submitted a written report. I'll just pull a few things out of it and extend 1 or 2 points. The first thing, and the good news, and obviously no complacency here, but the numbers are down of active positive cases. The live number this minute at the University of York is 55. York St John yesterday was 10. There's just a very small handful in York College and Askham Bryan College. So good news there. Big focus at the moment on the end of the academic term. Higher education institutions have received Department for Education guidance on this, especially about the movement of students back to family homes where students can and wish to do so. Just as an aside, our colleges are awaiting guidance for the further education sector. There are different issues there, and I think they hope that guidance will be with them soon. For higher education, for universities, there is a travel window, so-called, that will open following the end of lockdown on the 2nd of December. The travel window will be from the 3rd to the 9th of December, in which students are recommended to move to their family home should they wish. They don't have to, they're recommended to. The 9th is the last day to account for the possibility that somebody may test positive on the 9th and require consequential household self-isolations. That leaves 14 days for self-isolation, and you can still get home for Christmas just about. So that's why it's from the 3rd after lockdown to the 9th. We're planning to manage departures carefully. We imagine that more students will be picked up by family members than would be usual, so we'll look to manage arrivals to prevent too many people accumulating at the same time. I should note that many students will also stay at the university or in the city. We normally have 1,000 or so at the University of York on campus. There may be more this year, and we're putting together a package of support for them, which will of course depend to an extent on the restrictions that are in place at that time. Those announcements about the travel window were connected to announcements about the rollout of mass testing capabilities to universities. Both universities in the city have expressed interest to host such facilities. We don't have final decisions yet, but we have a firm expectation that this capability will be in place, and we've written to students at the University of York this afternoon to tell them what we expect will be available to them. This will be testing through lateral flow devices. It's the high volume, rapid turnaround testing, which resembles pregnancy test kits. We're working very hard now already on logistical preparations. You need big halls to do this, so sports halls come into play, where you can set out a lot of spaced booths to carry out the tests. We're recruiting staffing. It's going to be a significant and intensive effort, and we have a booking system under development for students to arrange to have tests done. The expectation is there'll be 2 tests a few days apart, and the hope is that students will get a negative in both and, in a sense, have a real sense of assurance about the movement from the university household to the family household. That will be especially important, I think, for students who do have vulnerable family members they'd like to see over the break. We are assuming, and this is the expectation of the government, that the go-live date for tests will be the 30th of November. So just 12 days away. So it's going to require a lot of effort very quickly. We aim to make testing available to all students who want a test, and we'll be encouraging a high take-up, but I should stress this is a voluntary scheme. It is not a requirement, it's not a precondition for travel. Those testing capabilities will also be important for helping to manage the January return of students. There will be a risk of virus transmission when students move from the family household back to the university household, and this testing capability will be an asset for us in helping to manage that. Won't be a silver bullet though. That testing capacity needs to hang together with effective contact tracing, and through our own work on contacts within the university community and the new local tracing capability, I think we're in a pretty good position there. But it also hangs together with self-isolation. And in a sense, that's the crux, because if there is somebody at risk of transmitting the virus, we need to have them in self-isolation. And following on from what Claire said in the communications report, there is a fear of self-isolation fatigue, especially when it's connected to the financial challenges that many students face. Self-isolation may mean the loss of income from casual work, and many of the bars, restaurants and other casual jobs in the city are carried out by students who rely on that income to support their way through university. So against that background, I have asked, together with our Students' Union presidents, for the government to consider self-isolation financial support for students like that available to others on low incomes and or on benefits. I'd like the advisory board to consider whether it could imagine supporting that call and reinforcing that request to government. I shall stop there, and I'm very happy to expand on anything colleagues would wish me to do.
Thank you very much for that, and open up the item for any questions or comments. What I can say is I'd certainly be very happy to write if other board members are happy, perhaps jointly with you, Charlie, broadly on that topic of financial support to ensure that, as you say, it picks up not just those on low incomes or, for example, on benefits, but students and those that need it, so that we don't then risk, as you say, that self-isolation fatigue. So I'd be very happy to do that, and perhaps the board could delegate that to us outside of this to agree that and send it off. I can see quite a few nods, but I'll open it in case there are any particular comments now. If not, I will take the nods as yes please, write that letter, and then we'll obviously make sure we get that circulated to all Outbreak Board members so that they can see that. Does that meet that objective, Charlie? Great, super. Thank you very much for that, and indeed all of the work across the universities and colleges in York. So that moves us to agenda item 6, which is an update on contact tracing, and I believe I'm handing back to Fiona to present this one. Fiona.
Yeah, it's just a verbal update really. When we met last, it was the day before we were going to go live with our local contact tracing service. So what I spoke about last time was all hypothetical really. So now I'm able to come back and tell you how it's actually been working. So tomorrow will have been operational for 4 weeks. And what we've dealt with over that 4 weeks, we've had a total of 225 cases that have been passed to us from the national team to deal with. And overall, we have successfully contacted 76% of those people and have been able to gather the details of any contacts, put those into the national system, and then make sure we can also give that advice and support, as you saw in that animation that Claire showed, to those people that we've had a conversation with. So on average, it's about 50 to 60 people a week that the team are speaking to. It does vary quite a bit week to week. And actually what we've seen, when I looked at the data for the last week, we have seen the number of people, or the proportion of people that we've contacted, go down slightly. And so we've looked into that a bit, and what we've essentially found is that when we started, the national team were passing us quite a lot of people that they'd not even attempted to make contact with. So we were getting quite a lot of people who were, by the time it came to us, that was the first time anybody had tried to contact them. So when we were working on that basis, we were contacting about 90% of people. That has improved from the national contact tracing team now. So what we are seeming to get through now is truly the hard to reach, who the national team have tried to contact and have not been able to. So as well as the phone calls that we've been making to people, we have also done a number of home visits, as shown in the animation as well, and they have been well received by people who've had those visits. And then the other thing that is probably worth mentioning is that we have got a good arrangement set up with the universities as well, and that partnership's worked really well. So where we have students who we are come up on our list that we would be wanting to contact, we're actually kind of linking in with the university as well to make sure that those students are contacted via the university route as well. So that's been working really well, and actually students are responding well to that as well, and generally picking up the phone when we call. So that's kind of been a positive, and also demonstrates the reason for having a local service, because we've got those kind of local relationships with our universities, and so we can work in that kind of partnership way to get the result that we're looking for. So we've had some really good comments as well from people that we have spoken to, generally kind of ranging from that the team have been able to provide clarification that people have needed. They've been friendly and professional, and they're able to answer the questions that people have. And then I think one of the other benefits that people have said of the local service is that, as well as those kind of 225 phone calls that we've made out, people can also ring back. So what does happen often is that you'll have that conversation with people, explain the advice, get the details of contacts, and then, you know, half an hour later, people start kind of thinking of the questions that they really wanted to ask. And with the national service, there's no way of ringing back. Once you've had that call, that's it. So we do get some callbacks as well, where people, having kind of processed the information, they now, have some questions to ask, and the team are able to go through those questions and answer them, and just give that reassurance to people. So all in all, it's been a really positive 4 weeks. And then thinking ahead, so the next steps will be really for us to expand that service, and that will come on to, when we talk a bit more around testing. So look to expand the capacity in that service going forward.
Thank you very much for that, Fiona. Sian.
Yeah, I was just reflecting on, is it working? I was just reflecting on the conversation we had about fatigue, and I was wondering, Fiona, did you get a sense from your conversations with people about whether they had already started self-isolating and they were complying with self-isolation? Because I think some of the conversations I've been having recently have been very much around people who had a symptom and then the next day they didn't feel bad, so they've gone, it must have just been a cold, and are carrying on. Whereas when people are getting a positive diagnosis, are they then acting in a different way? So I was just wondering about that, really.
Yeah, so the majority of people, so by the time we're contacting, they've been told that they've had a positive result, and the majority are following, that advice to self-isolate. We have come across cases where people have been a bit confused, or they're not quite sure exactly what self-isolation means, so they didn't understand whether if you're isolating because you're a case, that actually means you're not going out at all, so not even for daily exercise. So we've been able to explain that, and then we are still finding some instances where people hadn't realized that if they have tested positive, that also means the rest of their household need to isolate. So being able to explain some of those messages to people has been useful as well.
Thank you very much for that, Fiona. Question from me really was whether at this early stages you've got any sense on who the hard to reach groups are, and whether we can adapt our communication or messaging to try and find other ways of reaching them, whether that be by age, by likelihood to not have, for example, digital access, or whether there's any geographical clusters or areas in the city, or it's just too early to tell.
Yeah, no, that's really interesting, and that's certainly one of the things that we want to look at. I think we're not really seeing any patterns yet, so absolutely that would be the kind of aim, to learn from what we're seeing. So like you say, we can adapt those messages, but with the numbers at the minute, those patterns aren't coming through, but we will, as we get more numbers through, we'll look to see what we can sort of glean from that.
Thank you very much. So if we can thank Fiona and note her for that update, and that then takes us on to agenda item 7, which is the testing proposals. And I think I'm going to hand to Sharon first, and then there's a presentation as well that follows. Sharon.
Yes, thank you. Thank you, Keith. I just wanted to say a few words really before Fiona goes through the proposals with you. And that's to say that I'm really excited by the opportunity to be able to do more localized testing. We've been lobbying for this for some time, and this board has supported letters being sent to Department of Health and Social Care, saying that we wanted more control locally over testing and over contact tracing, because we believe we can do it a lot better, particularly thinking of some of those hard to reach communities across the city. But it is going to be hard work. in introducing this, and it's something that public health will lead. But just as we've done with communications and all the other work that we've done in addressing the pandemic, it will need a whole city response. So what I encourage you to do, as Fiona goes through the presentation, is perhaps to think about your ideas that can help support us as we take this forward, but also for your organisations that you're representing, your thoughts on how you might be able to support this population level testing program across the city will be very welcome as well. So that's all I wanted to say, Keith, before handing over to Fiona.
Okay, so what I wanted to do really was to just give a little bit of background in terms of what some of the new technologies are. And then to look a little bit in terms of what this kind of art of the possible might be for us in York. So I hope you can see those slides up there. So there's various different testing technologies that are coming on stream now. So obviously the PCR is what we're currently using. Most people are familiar with this. The biggest downside really of these tests is in terms of the turnaround time, at least 48 hours in most cases at the moment. So then what's known as the LAMP technology is basically a quicker way of turning around an accurate test. You've got a rate of false negatives of about 6% on those tests. And this is, I think we've heard in previously about the partnership with the University of York and the NHS. This is the technology that they're looking at within this partnership. And then we've got the lateral flow devices. And this is what's widely being reported on in the media at the moment for a solution to mass testing, as is being done in Liverpool currently. The proportion of false negatives can be as high as 30% with these tests, but it does depend a bit on what the viral load is. So in essence, it's very good at finding very infectious people. It is a quick turnaround, which is the main advantage of these tests. And again, the accuracy of the test is better when it's interpreted, when the result is interpreted by a trained professional. And also, there may be better accuracy in terms of knowing what the true result is if negative results are retested and positive tests are confirmed by a PCR test. So there's quite a few logistics in terms of understanding what the best way of getting a true result is, and some of that will come out when the pilots that are currently happening are reported on. So there's still some learning for us to understand. But as Charlie has already said, the universities have already submitted their expression of interest to use this prior to students going home at Christmas. And also it's worth noting that the NHS separately have also been asked to roll out twice weekly testing of their patient-facing staff as well. So just in terms of summarising then, so the symptomatic testing, as I said, that's what we already do. So there's no proposal to change that symptomatic testing. So we will continue to reinforce the message that if you have symptoms of coronavirus, you should book to have a test, and you and your household should self-isolate whilst waiting for the result. But the new technologies really have a role to play in asymptomatic testing, and we can basically split that into enhanced testing, which could be done in a way which is known as ring testing, whereby we're basically testing everyone that has been identified as a contact of someone that tests positive. Or you could target it to specific groups where you either know there's a higher prevalence or where you know that the risk of getting coronavirus is more serious. And then there's the kind of mass asymptomatic testing, whereby you are basically making it available to anyone in the population to access. So it's probably worth at this point, pointing out that no test is 100% accurate. And because coronavirus is a novel virus, there isn't any gold standard in which to compare any of these tests against. So there are studies being done. Public Health England reported last week on the reliability of the lateral flow device tests. And I think the evaluation of the LAMP technology was due to be published today. And there's been various studies reporting accuracy of PCR tests. The other thing that we need to consider is it's not just about how reliable a test is. The prevalence of the virus in your population has an impact too. So if you are testing a population where the prevalence may be higher, you're more likely to have false negatives. So basically where a test comes back negative when actually the person does have the virus. So that's just a few things that we need to think about when we're looking at which elements of the population that we want to test. But in terms of what we currently know about that reliability, I think our recommendation is that we wouldn't recommend what I talked about in terms of that ring testing. So whilst it may help in reinforcing the need to isolate in those that get a positive test come back, because of the rate of false negatives, it couldn't presently be used to end isolation in those that get a negative result. And I think that would be quite a complicated message to give out to people as well, and might lead to some confusion and would potentially lead for people to question the use of a test if it wasn't able to then say, actually, you can now end your self-isolation. That issue is being looked at nationally. So if nationally, as part of these evaluation studies, that position changes, we would obviously look at that again. But at the moment, if people have been a contact of a known case, the isolation would still have to continue. In terms of the targeted asymptomatic testing, it could be used as a way of identifying asymptomatic cases in where you know the prevalence is high, or as I say, in example, care home resident visitors. There is still an issue of false positives, but we think given the kind of trade-off in terms of people being able to do those care home visits, that this is something worth exploring, and also where we know that we've got outbreaks, it is useful in terms of being able to really kind of end that outbreak and be able to manage that in a safe way. In terms of the mass testing, again, we think that this could be used to identify asymptomatic cases at scale in our population and be a tool to bring down the rate of infection. But the other thing to just mention as well, and I think Charlie said it, there's no point just doing testing. We obviously need to have the resource to make sure that the public health action following test results can be followed through. So as I mentioned, we want to look at how we can expand the resource in our contact tracing team so that we can make sure that that follow-up support happens as well. The other issue, of course, around that as well is there is some clarification that we need from nationally in terms of if you have a positive test with using a lateral flow device, does it get added to the national database and get entered into that national contact tracing? Because being entered into the national contact tracing and having your reference number is what triggers you being able to access the isolation payments if you're eligible for them. So that's an important thing that we need clarity on from nationally as well. So in terms of doing some of that targeted testing, our proposal would be to prioritise the testing capacity that we have to firstly look at how we could use lateral flow tests to facilitate safe visiting to care homes. Secondly, to introduce regular testing for the adult and children's social care workforce. And then also, thirdly, to look at how we could use these tests when we know we have those outbreaks in particular settings. So whether that's universities or schools or in workplaces as well, to kind of help with that economic issue in businesses being able to reopen more quickly if they're affected by an outbreak. And then capacity allowing, our priority would then look to focus on geographical areas where we know rates are higher, which sort of starts to take us into some of that territory around mass testing. And then, you know, looking ahead as we kind of come out of this pandemic, and want to get back to some sort of sense of normality, looking at how you could potentially use those tests for economic recovery and, you know, for things like allowing events to go ahead as well. So just thinking in terms of the mass testing, so there's various different ways we could do this. So we could go for a one central location, that's our mass testing site for York, a central location whereby people would be able to come and, you know, book on, as Charlie described that they're doing in the university. So you can book on, you go and you have that test and you get that result within 30 minutes in that site. The other potential is that we could look to have one smaller central location with a number of smaller satellite sites out in some of the sort of villages or further out areas within the city. So a kind of a hub and spoke model. That's another option that we could look at. And then the third potential option is that you have a kind of a mobile testing unit. So you're able to kind of decide what area you want to focus on in any one given week, and you send your mobile testing unit down there and you advertise to people that, you know, that unit is visiting on a given day and people can come forward and be tested. So in terms of some of those, the sort of pros and cons about those. So with a one mass testing site, there's obviously an efficiency of scale. We can have all of our testing staff in one place and they can pick up the various roles. And in terms of any costs associated with a venue, we've only got one cost. Obviously, that does mean that then people are travelling into one city centre location, which could potentially raise issues for people in terms of access, and it might put people off actually coming forward to be tested if it's not, you know, an easy thing to do. The hub and spoke model obviously gives us some advantages in that we can get those spokes out into the outlying areas to mitigate against some of those access issues. And you could look at it sort of on a smaller scale of operating in a similar way to a kind of a polling station type model. And it would really be kind of looking to use what are those assets that we have in our populations that would increase uptake of those tests. And then with the mobile units, obviously, again, you know, that increases that access. You could have a rolling program, you know, of if smaller villages or areas being able to be part of that testing, and that would avoid that sort of travel into the city centre or travel to other areas. And then just quickly in terms of the lateral flow device to care home. So again, this is something in terms of that first priority of enabling visits to care homes. It would be a rapid test. We have a system set up at the moment with the PCR testing whereby for care home staff and residents, we deliver swabs as part of their routine testing, and Be Independent deliver those for us. So we could look to use that same route for these lateral flow testing. We would need to do some training of the care home staff. As I said earlier, if those tests are interpreted by a trained professional, the accuracy is much better. So we could look to put in place some training for care home staff to be able to interpret those, but have a sort of regular delivery to care homes so that visitors could access those prior to seeing their loved one when they're doing that visit. So quite a lot to sort of take in there, but as Sharon said, it's exciting new technology coming on board, and something that we'd be keen to look at how we enable our population to access that.
Thank you very much for that, Sharon and Fiona, and very happy to open it to questions or comments. I think from my perspective, a little bit as Sharon said, we all have individually and collectively lobbied nationally to get both more capacity and more support for testing, and I think some of our earlier conversations reflect that that's really important, but it's one piece of that jigsaw. Alongside isolation, and then the systems like the tracing working alongside that. So I'd certainly support the references that you made there to making sure that we seek clarity on support to enable us to do what we need to do to make sure that and all parts of the system work to make this an effective public health response in York. Question from me, there's been a lot of discussion about submissions of interest to the Department of Health and Social Care. I think it would be useful to understand timelines, and what do we have to submit and when, and certainly from my perspective, I think agreeing a submission of interest for both enhanced testing and mass testing alongside getting that clarity to make sure it works would absolutely be the way to go. But I'd be interested for a bit more information on the what and when to make sure that we do that and get that submitted. Who would like to go? Sharon.
Shall I answer that one? So there's no deadline for this. It's a rolling programme. And so in discussions that I've been party to, local authorities are being added onto that list. So there was the original list of 66, 67 authorities. That list is growing all the time as more local authorities say they'd like to do this. So in terms of process, if we agree tonight that that's what we want to do, I would send an email off to the regional person to say, yes, York wants to do this. There's then an application process that we need to complete, which basically is the information that Fiona's just gone through about how the groups that we particularly want to target and what percentage of our population we think we want to test, and how many of these lateral flow devices we would need. That then goes in and it gets considered. They're being turned around quite quickly. So by the time we submit our expression of interest, we should hear within a week or so whether that's been successful or not. And then it'll be negotiating around a timescale. We need to be ready to receive the lateral flow devices. So as soon as we can have all of those arrangements in place, then we can negotiate a date for receipt of those tests, and we can start doing what we want to do. So the turnaround is quite quick, but there's no deadline. It's up to us really when we decide to put that through.
Thank you very much. I'll start to go to others, and so you don't need to answer this second question because others might have comments on it, but I would certainly support a model where we're not relying on one centre. I think where we've had both the drive-through and then walk-in centre, as well as postal options, clearly that's supported different parts of the city and those that will have different preferences for how to access it. So whether that's a mobile model, if that is flexible enough, or other centres, I'd certainly support that principle of not just basing it in one place to enable that widespread access. But others, I'm sure, will have a comment on that. Lisa.
Thank you, Chair. 2 questions from me, if I may. Firstly, there's been some anecdotal information that people are not answering the test and trace calls because they don't want to isolate for 2 weeks for either economic or personal reasons. And how sure are we in York that people want to take up testing for exactly the same reason? So are people moving away from and avoiding testing because they don't want the outcome should they be positive? And secondly, is there any indication that there's a move nationally or through the health service towards conditional testing to grant people additional freedoms if they have been tested and have a certificate of some sort, and therefore might create an encouragement for people to go and be tested? Thank you.
Shall I start, Fiona, and then you can add anything? Yes, I think most of us will have heard those anecdotal reports. For me, and I've been on 2 calls recently with the Director of Public Health in Liverpool, listening to their experience there. And his view is that it's all about communication. It's about how you get really good information out to people, so that they can make informed choices about whether they want to be tested, because it is voluntary. We're not going to force anyone in the general population to have a test. And also then, really importantly, how they can then be supported, which builds on some of the conversation we had earlier. If you're in a job where you can't work from home, and if you're in a job that is, you perhaps don't have particularly good, sickness payments, or you're in unstable employment where perhaps, I've heard cases of people saying they've been given threats by their employer about, they need to come into work. That's why a whole city approach and those good communications are key, because businesses have to be supportive of this, employers have to be supportive of this. And we need to think how we can come together as city partners to get those messages across, and then continue to lobby for appropriate financial support for those people that need to self-isolate, so that if they don't need to be scared about having a test, or worried about how they will feed their families, or worried about how they pay their bills. This is a public health pandemic. It's a public health emergency. And I believe very strongly that actually, that it's a responsibility of government to support people so that they are able to follow that public health action. So I think that will make the big difference there. And then in terms of, these so-called passports, that you can have a certificate to say that you're COVID free. I don't think there is enough understanding yet to be able to do that. I know it's something that is being discussed nationally. There's a lot of work going on looking into that. As Fiona indicated in her presentation, part of that is looking to see whether these new lateral flow devices and more frequent testing will be able to reduce the length of self-isolation so people can go back to work quicker. All of that is being looked at. But at the moment, there is no change in the national guidance. Hopefully, we'll start to get more information through as the Liverpool pilot is evaluated and as more research is done. But I think that's a bit further down the line. I don't know whether you want to add anything, Fiona.
I suppose just the only thing to say is, the government, when they're offering areas to do mass testing, they're suggesting, the maximum is that you'd be looking at 10% of your population. I think Liverpool have almost got to near to doing the 10% now as they're coming sort of nearer the end of their 2 weeks. So yeah, I don't think, we're expecting, that this is something that everybody will want to take up, but, it's one of those things that, we'll probably only know when we actually do it.
Thank you very much. Charlie.
Thank you, Keith. Fiona made the comment right at the start that we need a whole city response, and I absolutely endorse that and would be very keen to see how we can coordinate our activity across all of the mass testing capabilities that we will soon have. In addition to the availability to local authorities, which we've just been told about, we will have that capability at the two universities. And I, for one, would certainly want to see that as part of a system to help manage the risk of virus transmission across the whole of the city. Fiona also mentioned that there is a further initiative underway, which is an NHS universities collaboration involving the hospitals and the universities in both York and Hull, working together around the LAMP testing methodology, in particular to support testing of NHS staff, but with a capacity which can also feed into universities and perhaps help unburden other parts of the local system and make a wider contribution in that way. So I'm very, very keen that we open out those conversations to think of all of the testing capabilities and make sure we get them aligned and side by side so that they really serve our communities.
Thank you very much for that. Alison.
Yeah, just to agree with you, Keith, that I think whatever model we go for, it's got to be accessible to everyone. So mobile or hub and spoke. But I've just got a question about the priority area of adult and children's social care workforce. Does that include the voluntary sector workforce? And if not, can it, please?
Yeah, I mean, I think we sort of take that for shorthand. We know throughout this pandemic there have been, social care staff, and particularly the staff that are kind of outside of, the formal, so domiciliary care, informal carers, voluntary, those ones who kind of haven't been picked up within the routine PCR testing that's currently happening. So yes, definitely, it would include that workforce too.
Thank you very much for that. So from the comments that we've had so far, I've jotted down a few sort of almost recommendations that I think are the sort of direction of travel for the conversation that I'll just check. It seems that the first one is that we endorse the whole city approach to testing. The second one is that we do submit the expression of interest to the Department of Health and Social Care for enhanced and mass testing. The third one is that we believe that it should be a mobile or the spoke model to ensure as wide an access as possible to be determined by the local public health teams. And the fourth one is that we continue to seek nationally, alongside this, clarity on making sure that the test, trace, isolate and support part of that overall system works, and that we get the right support and financial support in place to support those efforts. Hopefully that's a fair summary, and I'll come back in a second to Fiona and Sharon to check that, in a sense, answers your questions at this stage, but I'll just go to Julia before I do that. Julia.
Thanks. I suppose I'm just sort of thinking what happens afterwards. So presumably the evidence that we get from this will then be used to support any negotiations or whatever we might have around future tiers. And so, because I noticed the commentary coming out of government at the moment is that they don't anticipate anybody being in tier 1 at the end of this lockdown. So presumably that's one of the important aspects of this.
So the main reason for doing it is, mass testing or enhanced testing, mass testing is one of our tools that we can use to manage the pandemic. And until a vaccine is available in large enough quantities to be able to offer that vaccination to the whole population, we're going to continue to have to do the identification of cases, how we manage outbreaks, limit the spread of infections. So I'm working on the assumption, Fiona and I were having this conversation earlier this afternoon, we're working on an assumption that we would need to have this testing and contact tracing capabilities in place, and probably until next autumn, when hopefully we will have a mass vaccination program available for people, and COVID essentially becomes a vaccine preventable disease. That's the direction of travel. And I'll be talking a little bit about the COVID vaccination program in a minute. So that's the direction of travel. But I would agree with Keith that, testing's not a panacea. It isn't a silver bullet, whatever analogy you want to use is one of our tools. But washing hands, wearing face coverings, social distancing is going to be really important as well, and all of those basic cross-infection measures. So this will help alongside all of those other measures that we've already got in place, and until we've got a vaccine available on a large scale would be my view. So we'll be looking to do this for at least 6 months, possibly longer.
I suppose what I'm just thinking about the economic impact again, Sharon, as opposed to the spread of the virus impact. And anything that we can do to build an evidence base to allow the economy to get sort of restarted or develop, I think is equally as important.
Yeah, I would completely agree with that, and I think the hope. More research is happening on this, but the hope is that by introducing these new testing technologies, we'll be able to reduce the isolation period, so that instead of people having to self-isolate for 2 weeks, their families, all of the impact that has on the economy and schooling and people's lives, that testing will be one of the ways we'll be able to manage a way out of this pandemic. But because these technologies are new, the purpose of the pilots and more local authorities getting involved will be to, as you say, look at all of that evidence, and hopefully what we'll then be able to see is a change in national policy and guidelines that will start to benefit the economy by people not having to self-isolate for so long. That's the hope anyway. But I think that's the direction of travel, Julia, but I can't say how long it's going to take us to get there, unfortunately.
Thank you very much for that. So I sort of summarised into 4 potential recommendations. Just want to check with Fiona and Sharon. Did they make sense, and did that give you, with obviously all the comments from the board members, enough of a steer now to take forward that work that you're doing?
Yes, I think so. That was the purpose of this discussion, really. I was keen that we didn't submit an expression of interest until we'd had an opportunity to discuss it here. I think the discussion's been very welcome. You'll be hearing from us again as we develop that whole city approach to testing. But yes, I think we have everything we need to submit our proposals. Thank you, Keith.
Thank you very much. So I just want to check around. If any board members don't agree, now would be the chance to wave madly at your screen. And obviously, given that that's quite a big recommendation, I'll ask for a show of hands in a second. But just to recap, so that's to submit expression of interest for enhanced and mass testing, to agree a whole city approach to testing, continuing the work that partners have done, to seek alongside that clarity and support nationally, particularly on that testing, tracing and isolate must work with that required financial support that we've discussed earlier on isolate, and that whatever model the public health team develops must include either mobile or spoke provision to make sure that there's as wide as access as possible. So could I see those in favour of those recommendations, please? That's great. Thank you very much. That's a clear majority in favour of that. So thank you very much for your comments and equally those presentations, and an awful lot of work that will now take place to make all of that happen. So that then takes us on to agenda item 8, mass vaccination. So another big piece of work, and I'll hand back to Sharon.
Yes, thank you. Chris, you're bringing up the presentation for us, I think. Okay, so there are a number of colleagues on the call who will know a great deal about this, our NHS colleagues, so they may want to add something at the end. But I thought it would be helpful just to bring something to the board to update you really on some of the planning for the COVID vaccination. So this is being led by the NHS with support from local authority, public health teams, and wider council support as is needed. York is part of the Humber Coast and Vale Healthcare Partnership. That's the wider health system that York is part of. And so the planning for vaccination is happening on that Humber Coast and Vale footprint, and its declared mission statement is to vaccinate the eligible population of Humber Coast and Vale against COVID in order to minimise the health and economic impacts of the disease, recognising the discussion we've just had about the impacts of COVID on the economy. And for York, we're part of our planning footprint is North Yorkshire and York. And there are already a number of meetings being established and discussions happening involving the North Yorkshire local resilience forum with other partners, and particularly with NHS trusts and GP practices are absolutely key to this. So moving on to the next slide, please. So just some key facts. You will have be familiar with this. It's been reported in the national media. So the government is intending for this to be a mass vaccination programme. They have ordered 40 million doses of the Pfizer vaccine, 100 million doses of the vaccine being developed by Oxford University and AstraZeneca. And in the news just this week, they've ordered 5 million doses of the Moderna vaccine. One of the reasons I wanted to put this in is that it adds a bit of a complicating factor to a mass vaccination program when you have 3 different types of vaccine that's available. And so in terms of the governance of that and the clinical safety of that, that's one of the issues that we're looking at the moment. For all of these vaccines, at the moment, we believe that 2 vaccinations will be required, either 21 or 28 days apart, dependent on which vaccine people have. And I just want to make the point really that all of these vaccines will have been widely tested and are safe. There's a lot of noise in social media that we'll all be aware of in terms of safety of vaccines. All vaccines have to meet robust standards of safety and effectiveness before they're released for use. And so going back to our communications that we were talking about earlier, getting the right communication and information out to people around vaccination is going to have to be a key part of our strategy. So moving on to the next slide then. This is what we understand at the moment are the population cohorts. So can you move on to the next slide, please, Chris? So this is the interim advice from the JCVI, which is the national committee that advises the government on vaccination. Because we know that the vaccine will obviously be produced in large quantities, but we know that the whole world is wanting access to these vaccines. So we're expecting them to become available in a phased approach. And so these are the initial population cohorts. So older adults resident in a care home and care home workers first. Then moving on to all those 80 years of age and over and health and social care workers. And then as you can see, the prioritization list goes down by age. So the priority groups will be the ones listed there, and the rest of the population priority to be determined, it says there. So there's some further work to do as to how vaccination will be prioritised for those people under 50 years of age. And as you can see, that's being split into 2 phases. So on to the next slide, please, Chris. So there are 3 cohorts in phase 1. And this is what the NHS and particularly primary care networks and GP practices are planning for at the moment. So care home residents and workers as a priority. NHS organisations will be vaccinating their own staff. So, you know, the hospital, as with all NHS trusts will be thinking about their plans for vaccinating their staff. And GP practices are busy looking at their planning. And then the over 80s are in that first cohort as well. So on to the next slide then, please. So just a little bit, this is the last slide here. So this is just a bit of information about where we are in terms of our planning at the moment. So phase 1 is NHS led, predominantly via GP practices. Phase 2 is NHS led as well, but this is about vaccinating much larger groups of people in the population. And so there are discussions that are already taking place with the Local Resilience Forum, as I said, about how wider partners can be mobilised to support the NHS with a successful delivery of the vaccination programme. There's a lot of learning we can take from the seasonal flu vaccination program. So just thinking about York, there was a they tried a new way of delivering the seasonal flu vaccination this year using the drive-through on Moor Lane, which has been evaluated very successfully. And again, a lot of partners involved in supporting that vaccination program, so we can learn from that. But we're still awaiting further guidance. I don't know whether Sally Tyler might have more information about this as a GP and LMC rep. But as far as I'm aware, we're still waiting confirmed timescales for the rollout. So the hope is that a vaccine will be available before Christmas. But clearly there's more work that needs to be done nationally on the logistics, etc., of the rollout of that vaccine. So we haven't had those timescales confirmed yet, but obviously we'll be making sure that communication comes out around that as soon as we know. So that's all I wanted to cover, Keith, just a bit of an introduction, really, an overview. I
think you've muted yourself just at the end.
Oh, sorry. I'm just saying, you know, there may be others on the call who want to add something to what I've already said.
Great, thank you very much. And before I open it to questions and comments, I'll go to Sally first, as you mentioned, really, to hopefully hear a bit more about preparations in primary care. Sally.
Thank you. I'm afraid I don't know any more at this stage, Sharon, in terms of the details around a date for delivery. I think it's fair to say it is a rapidly evolving situation at the moment, isn't it? We're getting new information by the hour. Practices have been asked to work together, so I think it's important to just make clear that certainly in the initial phase of the vaccine programme, it's unlikely that patients will be going to their individual GP surgery to receive this. We've been asked to work together at a primary care network or larger, so that's groups of practices together. Although we've been asked to ensure that we're ready to start by the 1st of December, I think there is probably an unwritten recognition that it's likely to be nearer to Christmas before we actually get the firm details and any proposed delivery of vaccines. But there is still a hope that we will be able to start this for the most vulnerable before Christmas. I just wanted to echo a couple of things you've said, really, Sharon. I think it is incredibly complex given some of the details around how the vaccine needs to be stored and the fact that there's more than one vaccine. But I have every confidence that together we will manage that in a safe way. I think the safety is absolutely key, and I would echo what you said on two counts. One, I think the communication to the public is going to be absolutely key. There's little point in having a mass vaccination programme for COVID and hoping that this will be a really successful part of trying to get the community back on its feet if a significant chunk of the public don't feel confident enough to have it. And I absolutely have confidence that there haven't been corners cut, and this has gone through all the processes that any other vaccine would go through. It's just that there has been a significant will and collaboration across the world, and money has not been an issue, whereas normally there are many other factors and hurdles involved, and people are unwilling to take the number of risks that they've taken with this. And by risks, I'm not talking about risks around developing the vaccine. I'm more talking about risks around the sizes of the trials that have been run, and some of those have been run concurrently, whereas normally pharmaceutical companies would run them in sequence, and you'd have a very small trial and test to see if that worked, and they wouldn't want to invest any finances on a larger trial until they knew the smaller trial had worked. And because this has had such global importance, they've been able to run those concurrently. And I think it's just really important to emphasize that it will be as safe as any other vaccine is, and will have had very rigorous testing. And I think my only other point would be, and again, you've already touched on this, Sharon, I think this has to be a huge community collaborative effort. It can't be down to one individual partner, whoever that might be, to try and deliver this. I think there is a real challenge for general practice to be able to deliver it purely from a workforce perspective. So there's a huge willingness and enthusiasm to try and get behind this, but with ongoing challenges like all organisations have in terms of staff needing to self-isolate, where we can utilise other members of the community in a volunteer capacity, I think we will be really keen to try and do that. And it may be that we need to think about some comms around that at some stage, once we've perhaps got more of an idea around what the bare bones of the testing sites are going to be and what we might actually need. I think that's probably all I've got to say at this stage. Thank you.
Thank you very much for that. Appreciated. I've got quite a few hands up with questions. So what I'm probably going to do is take them in two groups and then come back for answers, if that's okay. So first to James.
Okay. Thanks for that presentation. I just want to kind of pick up on what Julia was talking about earlier about the economy. So if we're thinking about planning the recovery of the economy over the kind of next 12 months and beyond, best advice, looking at the practicalities of rolling out mass vaccination, is that there's going to be at least some form of restrictions, be that just social distancing or whatever, through to at least kind of autumn next year. Do you think that's kind of the kind of best case scenario if businesses are planning the next year ahead?
Thank you very much. If you keep the question, Sharon, and as I say, I'll come to you. Julia.
Thanks. Oh, you hang on a minute. Disappeared.
You're on.
Back again. Sorry. So a couple of things, Sharon. Is there a sort of target? It's probably too early to say as to ultimately what percentage of the population would need to be vaccinated in order to sort of stop the virus in its tracks, if you like. I mean, obviously there's still be cases, but to stop it really replicating. And then the second thing is to pick up on the point that Sally made, and I've been talking with a number of friends and colleagues actually who are GPs or work in primary care, and the resilience of staff and the ability to deliver this is they're feeling tired, exhausted. People have been through a lot. It's making sure that we can support people as much as we can to deliver this when it's being relied on through primary care, and then the implications of primary care not doing other stuff as well. So a couple of questions really.
Thank you very much. And Sian.
Yeah, I just had a question. Given that there are complications around the storage, is there anything in the guidance around the involvement of community pharmacies and how this might be kind of how much they might be involved in the primary care network plans for this?
Thank you very much. If I go to back to you, Sharon, on those first three, please.
Okay, so in answer to James' question, this is a really difficult one, and I was going to raise this under any other business, Keith, but I'll mention it now because it's linked to this. So I've been in 2 meetings this week with business leaders in York. And we had lots of discussion there about restrictions. And what impact testing might have, what impact the vaccination might have, and I think it's fair to say that different businesses have different views on whether they would prefer a level 1 restrictions or whether they would prefer level 2 restrictions. They're concerned about if York went into level 1 and the rest of the region went into tier 3, what would that mean for York? Lots of concerns about financial support for businesses, and also the impact of COVID and EU exit as well, and all of that. But the key take-home message for me from both of those meetings that I said I would raise at the board tonight was the level of uncertainty that this means for business. And I know, James, we're having a focus on the economic impacts of COVID at the December meeting, and I know you'll be leading part of that discussion. But I wanted to raise it here really to see whether there is anything more that we can do as a board in advocating really how important it is for businesses to have as much information and as quickly as possible about what's going to happen and what the government's intentions are around the different tiers. Are we going to go for the Scottish model? Are we going back to the 3 tiers? Are tiers going to be on a local authority basis or on a regional or sub-regional basis? And I can't answer that. And it was really difficult in both of those meetings with those business leaders who were asking for answers that I couldn't give, because we're waiting for the guidance in the same way that their businesses are. So I said I would raise that here. In terms of Julia's question, I don't know, Sally, whether you know any more about this, but my understanding is that we're aiming for 75% take up of the vaccine. That's my understanding, which is similar to the threshold that we try and reach for seasonal flu. So we're not aiming to vaccinate 100% of the population because there are likely to be reasons why some people wouldn't be able to have the vaccine, medical, clinical reasons, and some people by choice wouldn't want the vaccine. So I think we're aiming for 75%, but there'll be further information.
Sally,
out.
did you want to come in?
Only to say I think that's my understanding at the moment. I don't think anything's been absolutely confirmed, and primary care hasn't been given a specific target, whereas it's normally given targets to meet for the flu campaign. But it would probably be in that sort of region.
Yeah, that's my understanding. And then your other question about support for primary care, Julia, absolutely. And those are some of the discussions that we're having through the LRF to look at how we can mobilise support for GP practices. And at the moment, I think we're waiting for primary care networks to develop their plans, so that they're clearer about the support they need and the asks of the wider system. But I've already started some of those conversations in York, and I have made an offer of support. So I'm just waiting to hear back really what sort of support practices would want. And then in answer to Sian's question, yes, my understanding that community pharmacies will be involved. I'm not sure that they will be directly involved in the first phase, but I'm sure primary care networks, just as they work with community pharmacies with seasonal flu, will be wanting to work with them around COVID vaccination as well. And storage of vaccine is one of the logistical issues that Sally referred to earlier. Massive logistical issues, but we're still waiting for some further guidance and clarity around how some of those are going to be managed.
Thank you very much for those. And as you say, we've got an agenda item down in December around the economic analysis that James is going to lead with the council's economic growth team. So I think it'd be really good if James and Simon could bring to us then some thoughts from the business community on, what clarity would be needed, and then whether we can answer it locally or whether we can ask for that clarity nationally. And there's a few more questions that I'll come back to you on. I should say to everybody, apologies for my timekeeping, not keeping us to our projected end date, but given the significance of a couple of items, I thought it was important to let us run on a little bit, but I might speed us along after this. Alison.
Yeah, just to say about the volunteering workforce. So I've been in conversations this week nationally and across the Humber Coast and Vale and locally about how we sort of garner support from volunteers to help out with the mass vaccination. So I would urge a coordinated response, please. We don't want any ad hoc stuff going on. So if you can speak to me if you're looking at volunteers for this, I'd be grateful.
Thank you for that, and I'll go back to Sharon in a second and to Mark.
Yeah, just further to the prioritization of how the vaccine or to where it will be delivered, to whom it will be delivered. I guess has any thought or will any thought be given to what we would class as key workers, essential workers beyond the health sector? But I'm thinking those that need to keep essential services running, transport, obviously, and link back into the recovery and the economic recovery that James was talking about.
And to Sharon again.
Yeah, absolutely, Alison. What we want is, again, a whole city approach to deliver a successful vaccination programme. Yes, absolutely. You're already linked into Nimbus, aren't you? We're taking the lead on this, so I'm sure they will link into you. Absolutely agree with your point, Mark, about wider key workers, and we are feeding that up the line. Through the Association of Directors of Public Health Network, we are raising this, and I'm sure that there will be others lobbying as well to say, this vaccine provides a way to improving our economy as a country. It's not, we don't make decisions around prioritization locally. Those decisions are made nationally, and then we're expected to follow that national guidance. But I understand completely what you mean, and we'll continue to lobby upwards when looking at that prioritization framework, particularly when we get to the wider population, and prioritization within that wider population about some of those other key groups. So I would agree with that.
Thank you very much for the presentation, but equally all of the questions on that item. So if we note all of that information, I'll move us on to agenda item 9, and this is a report that's been produced by CVS and Healthwatch, and I'm going to hand over to, I think, Alison first, but also Sian to introduce this to us. Alison.
Yeah, so I've just had a quick chat with Sian, and to be kind to all of you, we're going to cut our presentation right down so you can all hop off shortly. So I'm just going to talk about what we're doing now rather than what we did before, if that's okay. You've got the report so you can read it in your own time. So just what we're doing now is pretty much part of what we did last time. So we've got the helpline back in place with GPs. So anyone who calls a GP who doesn't really need medical help, and 92% of the calls in the first wave didn't need medical help. They just needed social support, really. So that's back up and running with our social prescriber link workers. The monitoring hub's up and running again. So we're monitoring people with a small team of volunteers. So people who have diagnosed with COVID, we call them on a daily basis to see how they are, to make sure they don't fall through the cracks. We've got our welfare volunteers back up and running as well. We've had money from the lottery, so we can give our conference rooms for free to charities who need to still open and meet people in a safe space. We've got the volunteer centre up and running now. So this is a new thing for York. We've got the volunteer centre, so we can start to recruit volunteers and put them where the need is. The wider sector, we had a meeting of 50 organisations in September just for planning. As a result of that, we've now got a directory of who's doing what during COVID, which we can share. It's for professionals and people working in the sector rather than for the general public. We're working with the NHS responders, so I'm sure you've heard about this national initiative that came in, costing millions of pounds, didn't really link with local. It is here, so we are going to try and work more closely with them, and really I would encourage organisations to refer people in. If people need help for lots of different things, call them because they're here until March next year in any case. So one of the things that you might be interested in is we are monitoring issues that come our way. So we're talking to the sector regularly to find out what's happening and what they're concerned about. So if, for example, we hear that they're being overrun with requests for food, we will raise that as a system to sort of see what more resource we can put into that for them. Just very briefly on the impact survey, we did one in April, and I think I probably told you all the great news that 2 out of 3 charities may not exist within 12 months. We've redone that survey now across Yorkshire and Humber. The results are still the same. The timeframe has been pushed back, but we've still got 2 out of 3 charities who may not survive the next 12 months. Demand is up, income's down, and there's not a lot of capacity for leaders to look at how they can become more sustainable. So we're working with the sector, reaching out to them, and trying our best to put in practical help for them by offering support by way of people to help them out with some planning. And that's it. So we're here, we're up and running, but we are entering a critical stage in the months ahead for the sector, I would say.
Thank you very much for that, and equally changing your presentation at this stage is appreciated. Sian.
Okay, I think Alison's said everything that you need to be aware of at the moment. I think that the main thing is you've got the report. It details what some people are experiencing during this. And I think it's really important that's in the public domain, because I'm still speaking to people now who haven't personally been affected and don't really know what is happening for people when they're unable to access things that they need. So just wanted to make sure that was out there and available to people to get an understanding of what people are going through.
Thank you very much. I think to sort of put on the record, in a sense, thank you to the work of your 2 organisations as well. And I agree that those themes that are highlighted in terms of what people are raising are really important and run alongside a lot of the work that Claire presented earlier. And I think it would be great to make sure that we capture that alongside some of that city survey work, again, to make sure that our messages are as good as they can be, and they're getting across to the right groups of people. So I can see Claire writing down. I'm sure we'll have some conversations with you as well. Sharon, did you want to come in?
Yes, I just wanted to express my thanks to Alison and Sean and the teams that they work with that have done an incredible job and continue to do an incredible job. But you beat me to it, Keith. So I just felt that we should formally record our thanks in the minutes.
Thank you very much, Sharon. I could see everybody, or the vast majority, nodding along with that. So I'm sure we'll record that in the notes. So thank you, Alison and Sean, for that and the report, which we'll note. That takes us on to agenda item 10, which is items for the next agenda. So we'll have our standard agenda items. Please do contact us if you've got any suggestions in the meantime, or obviously we'll add things to the agenda as and when they happen. And as we mentioned earlier, we will have that economic analysis item on the December agenda. I can't see any other hands, so just to say, contact us outside of the meeting if there are any others, and if we could note those future agenda items for now. Agenda item 11 is dates of future meetings. So our next meeting is on the 9th of December, and you will have seen as well that we have now put meeting dates in if we need them for January through to May. So hopefully you've had all of those meeting dates and invites in your diaries. Obviously that's assuming that we'll carry on monthly, and that's subject to change whether we need more or less depending on the situation at the time. So if we could note those future agenda dates. And then the final item 12, any other business. Sharon was going to mention here some of that impact on discussions with businesses, but we've covered that earlier, and we'll make sure that we pick that up in the report that comes through to the December meeting. I don't have or know of any other business. So just a quick look round to check nobody is now madly waving at me as if we've forgotten anything. So the final thing is just to say thank you all very much for your input, questions and time. It's appreciated as ever, and I will see you again next month. Thanks all. Bye-bye.